So now I'll hand over to Dr. Lomi, who's going to tell you the steps for surgical management.
Thank you, ma'am. So I'll be speaking on a customized surgical treatment in PUK, the matches and the patches. So I have no conflict or financial interest to disclose. So corneal perforation is an acute complication in PUK, commonly seen when there's cases with multiple recurrences, inadequate immunosuppression, or when there's poor compliance to treatment. So when is the surgical indication required? When there is increased depth of melt leading to desmatocyl formations, or when there is impeding perforation, or in advanced extension of the melt circumferentially or centrally. And also for rehabilitations, for visual rehabilitations of the ectasia, and also in severe astigmatism, and for structural stability of the residual thinning. So when is the customized surgical procedures done? And it is done with when there is a procedure is chosen depending upon the size, shape, the location, and the extent. When is a very small perforation, less than 3 millimeter, the tissue adhesive with bandage contact lens is used. Tuck in tenon patch graft can be advocated for 3 to 5 millimeter of perforations. Sometimes this tuck-in laminar keratoplasty can be used for larger graft and also for larger perforation, tectonic penetrating keratoplasty. Laminar graft is an option, better option for because there is less chance of graft rejections, and sometimes you can use a sutureless laminar keratoplasty from the smile lenticles. So the matches and patches, here the donor tissue is carefully sized to match the recipient bed, and the patches the peripheral defect accordingly. So various shapes, depending upon the lesions, we can use it. The various described like round patch graft, the concentric, biconvex or elliptical, or banana shaped graft, or stencil based prick and print on a C-shaped laminar keratoplasty to take care of the astigmatisms. So it's a case scenario. This is like patients with bilateral PUK, which earlier it was tried the synovial glue with BCL, but there on the left eye, there's a recurrence perforation was there. So in this case, was subjected for this concentric patch graft surgery. First of all, you have to see where the unhealthy tissue is there. You mark that unhealthy tissues, preferably 0.25 to 5 millimeter involving the healthy tissue as well. And using a free hand with a Vanna scissor, you trim the unhealthy tissues. Here there's a donor graft, there's a tectonic graft. You use you place a stage suture over it, and seeing the underlying marking areas, you have you trim it according to the size and complete the suture. So this is post of day 1, and this is post of day 5. The corneal edema has reduced well now. So this post-op treatment option, Dr. Yogit has already very well explained that role of steroid, the doxycycline, vitamin C, and also the methotrexate and folic acid. So it has to be adjuvant along with the surgery. Surgery alone won't suffice. So this is a case with another circular patch graft where circular patch graft was done, and this is the post-op result. I came across this interesting literature, the stencil-based prick and print techniques for harvesting corneal shaped graft for management of peripheral corneal perforations. This is published in Cornea 2013 by Gautam Singh Parmar. So in this, they have done marking of the disease with host tissues and making a stencil using a thin transparent plastic, and make a prick on it on the lesions by using a 2-inch gauge needle, and this is followed by a linear cut with a blade uh, along margin outline of 0.25 larger, and using a surgical pan. The marking area has been stencil has been placed over the donor cornea, which is placed on the artificial chamber, and the excision of the shaped cornea was donor cornea was created, and is made the transplant was made, and that's on a very good result out of it. And The beauty is that it can make of any shape or pattern of the donor corneal graft without involving the optical centers, and also it can use for extensive peripheral corneal lesions. Here's another case scenario of neurotrophic PUK, where the small perforation was in the periphery. Here, the tenon patch graft was used in this case, and first of all, you have to harvest the healthy tenons, where the tenons have to be dissected from the conjunctiva, and the tenons mark that the tenons have to be larger, around 50% increase the size of the size of the perforations. A stromal pocket, 360 stromal pocket is created, and the incarcerated iris was reposited back into the anterior chamber, and this tucking of these tenons were made, and then which was secured using 10 or nylon sutures. Here we have used, along with the sutures, we have used a fibrin glue. Some surgeons use cyanoacrylate glue also, and make sure that the tissues are well reposited back into the anterior in its place, and followed by the removal of the aqueous of the viscoelastic tissue. This is make sure there's another bandage suture, the bridge suture was placed to make sure that the tissues were well in place, and this is followed by a bandage contact lens. So this is next post-op day. The wound is well secured, and the chamber is well formed. So usually that it gets reepithelialized. The reepithelialization takes around 3 to 4 weeks time, and the benefit of this tucking patch graft that it is easily available, and the procedure is repeatable, and it's very cost effective. So in a scenario where we don't have the cornea with you, that is also the possible options. Only drawback is that it heals with vascularization, and there may be leukomatous corneal opacity. Here's another case scenario of 13-year females with batches with a PUK, with 360-degree peripheral ulcerated lesions with surrounding avascular zone, and a necrotic scleral necrotic tissue with exposed uveal tissue was there. So a customized corneoscleral patch graft was performed here. The surgeon is our Madam Professor Radhika Tendon. So in this case, the necrotic tissue areas has been cleared off, and then using a tectonic donor cornea, we have trimmed that area. The extra scleral tissues were trimmed off, and this is placed over the host bed, and then this marking was done by looking it directly. You can see that area defect, and its marking was done, and using a free hand, the graph was matched, and then this was patched in the subsequent area along with this the necrotic scleral tissues. It was customized with and then cover up with the corneal the button. So this is the initial patients was hand moved close to face, and patient is now following more than 5 years now. Patient is like still maintaining vision. However, the patient have to go along with the immunosuppression for a very long time. Still was on a low dose of 5 milligram weekly dose of methotrexate. Another for smile-derived lenticles can be used for the paracentral corneal perforation of around 2 millimeter in these cases, where a smile lenticle was used for it's kind of sutureless, where you can use only a glue to suture it to place the graft. So in a scenario where you have smile facilities, you can take care of with these lenticles. The lenticle will give around 50 to 60 microns, which will help you for taking care of this such peripheral small perforation. So a study was done in a center with comparing the tenon patch graft and the smile lenticles in management of corneal defect and perforations to see the anatomical, the functional, and the ocular surface parameters. Where in these studies have shown that the tenon patch graft is effective for sealing a small defect of less than 3 millimeter. However, there is some corneal neovascularization and has higher astigmatism as compared with the smile lenticles. And the smile lenticles have better outcomes in terms of visions and also the ocular surface outcomes. Lastly, a compressive C-shaped laminar keratoplasty for rehabilitations of all of PUK's patients. After healed PUK, there might be a steepening and high irregular astigmatism will be there. So yeah, it can be taken care by using these methods by Cheng et al., which where they used two trephine. Trephine was used for marking, one inner one with 9 millimeter and outer of 14 millimeters, and the edge where to get a C shape, the outer edge was arc was marked by using a disposable dermatomes. And here the graph were undersized of 0.25 and 0.5 mm, and the compression suture was placed under direct visualization on microscope mounted keratoscopes, where approximately 50% astigmatism overcorrection in that axis was used, and it was found that it is very good in taking care of the astigmatisms without any recurrences in this short 6 months follow-up time. So in conclusion, match and page cornel graph have the advantages that every steps are performed under direct visualizations, following accurate mapping either by freehands or by trephine markings. And it's important to note that early surgical interventions is always helpful for successful restoring the tectonic integrity of the globe, and also improve and stabilize the visual acuity in perforated PUK. And most important is that it's a team effort of internists or the rheumatologists and ophthalmologists which will help us to use a judicious use of immunosuppressive agents, maybe for very long durations, and which can yield a favorable results without with minimizing the adverse effect. Thank you all for your kind attention.
Thank you so much, Dr. Lomi. Very nicely covered all the options to, globe salvage procedure and how to manage and a good range. And ultimately, you have to customize it depending upon your patient and seeing the scenario. And certainly, sometimes it is a little daunting, and you will find that you feel that the margin is very thin, and how will you fit that tissue in? In such cases, you can even bevel the posterior aspect, as he had shown. Little bit you have to use your own tailoring and surgical skills to match it. And regarding the tissue, even glycerine, it is an emergency. So in case fresh tissue is not available, you can even use the glycerine preserved tissue. The important thing is to, stabilize the eye as soon as possible. Thank you.